Bore da, diolch fawr iawn am gael dod yma siarad today. I always start off in Welsh because it kind of defines who I am. This is an interesting talk because it's full of questions, and Simon has already thrown out some challenges to me as President of the British Association of Sexual Health and HIV as regards ensuring that sexual health features in the 10-year plan. But my aim today is actually not to talk about that, but to look at, can we end the AIDS epidemic by 2030? In 2014, there was an ambitious plan put forward by UNAIDS to actually eliminate HIV by 2030. And on top of this, what the UNAIDS decided is that it felt that worldwide, 90% of all individuals would be aware of their HIV status, and with 90% of those people diagnosed with HIV, they would be on effective treatment, and hopefully 90% of them would be have an undetectable viral load. To get to this position, we have to look back to the past, and Simon's talk has reflected on where we were back in the early 20th century. Mine is looking more to the late 20th century. So when I was a medical student, it was a major thing. It was a new disease. 1981, papers in the New England Journal of Medicine identifying groups of young men in West Coast America who were being diagnosed with immune conditions such as Kaposi sarcoma and pneumocystis carinii pneumonia. This was an age of fear, ignorance and prejudice. No one knew what caused HIV AIDS. No one knew how to tackle it, and it was a major public health concern. And you can see from my diagram that in 1985, just after we'd had our first commercial test, the areas that were affected across the UK, across the world. And I know Simon referred to Norman Fowler, but if you've got very good eyesight, you'll be able to actually read the letter to Margaret Thatcher around the Don't Die of Ignorance. And you'll see that that campaign, which happened in 1986, was the biggest public health campaign ever to be launched in the UK, with 2-minute videos and adverts on all daytime and evening telly, and a leaflet dropped to every house in the UK advocating that people should be aware of this new killer disease called AIDS, and those at risk should go forward to get tested. At this time, what we really had was no treatment, no vaccine, and really it called for a huge amount of community response and activism. So very early on in the epidemic, the third sector, Terence Higgins Trust, which was a charity formed by the friends and family of the first person in the UK to die of AIDS. Then the National AIDS Trust was set up by government. They had a major part in ensuring that individuals, their friends, their families were actually supported in these early days. And then we had groups like ACT UP, who were really pushing for the development of new drugs for HIV. So it was a really difficult time, the first sort of 10 years of the epidemic. And then we went into a sort of age of optimism. In 1987, Zydoviudine was licensed and was given out a bit like Smarties initially. But then between 1987 and 1997, the development of antiretroviral products was considerable. And the seminal paper published by Gulick in 1997 actually showed us that the use of protease inhibitors in combination with 2 nuclease reverse transcriptase inhibitors would actually render the individual with a normal immune system, reduce their viral load, and actually improve survival considerably. And just look at what happened in those days. So if you look at where the heart comes up there, you'll see that there was an immediate drop in the number of people presenting with an AIDS condition, but also the death rate from AIDS actually dropped dramatically. But it had a very different impact on people's testing behaviours. So we can see that probably for the first 2-3 years, there was a flatlining on people coming forward for testing. But as individuals realised that their partners, their friends, people that they knew who were on antiretrovirals were actually living healthy and normal lives, they came forward for testing. And you can see right up until 2005, 2008, we actually landed up having the highest number of new tests, individuals testing positive in the UK at around 8,000 a year. But moving on from this time, this was good news about treatment, but it wasn't about elimination of HIV. And in 2008, there was a mathematical modelling exercise looking at what would happen if you started antiretrovirals early and if you actually tested everyone. And what this model showed is that if you look at the red line, if you did nothing, the epidemic would continue. If you just offered treatment, there would be a slight drop, but it would still continue just a flat line at a slightly lower prevalence in the population. But if you introduce treatment and testing, and very early treatment, then there was a possibility of eliminating HIV and AIDS. So what's happened in the UK since then? So these are the recent data. So you can see this is PHE data now from the beginning of the epidemic right through to 2017. And in 2017, we saw the lowest number of new cases literally for 20 years, with only 4,363 new. There are, however, still 101,000 plus people living in the UK with HIV, of which 8% are unaware of their diagnoses. So there has been progress, but has this progress been by chance or by a strategy? Simon's told us there hasn't really been a strategy, but I think latterly we're starting to get our heads around the fact that there are 3 things that we can actually do called combination HIV prevention that actually might help us eliminate HIV by 2030. It's 3-pronged: testing, treatment as prevention, and primary prevention. And I'll go into these in a little bit more detail now. So, we consider late diagnosis to be a never event. And the British HIV Association is now looking at doing root cause analysis on individuals who present with a CD4 count less than 350. And a recent pilot showed that this would be a very feasible thing to do, and that then the individuals whose diagnoses had been late, that we would look at why they had late diagnoses. In the initial pilot, there were at least 8 opportunities for some individuals to have had a HIV test and to have avoided presenting very late. If you present late, your morbidity and mortality is very much reduced, and as you can see by the chart on the right-hand side. But also what's been happening is the rates of late presenters in percentage of those presenting with HIV has actually not dropped that significantly over the years, and currently stands at 43% of all new diagnoses. That's 1,666. Sorry. So, HIV testing. So, Beaver and Bash, yes, we have very great names for our societies, introduced, thank you, HIV testing guidelines in 2008. And these are actually still in valid ones. And they actually recommend who should be offered testing, but also outline the indicator diseases that need HIV testing. So anyone who presents with TB, anyone presents with a community-acquired pneumonia, with esophageal candida, with cervical cancer, they are people that you should be offering HIV testing to. Now, in 2011, there was some action by Health Protection England at the time, who actually looked at whether it was feasible to roll out testing outside the sexual health clinics into areas such as the emergency departments and acute medicine and hospital admissions. It introduced HIV Testing Week, and then also NICE produced their first guidance on who should be tested. And you can see the chart there shows the prevalence of HIV by 1,000 population. The darker the blue, the more individuals are known to be living in those areas. So you can see London is a big blue blob, but there's areas around Liverpool, Manchester, Leeds, Birmingham, the Midlands, Brighton, and a few other places dotted around the UK where the prevalence is 5 people per 1,000 population aged between 15 and 19. Anyone, any idea of how many HIV tests are done in the UK in a year? Would you like to know? 3.7 million tests, right? So the majority of them are done, 1.6 million by blood transfusion, 1.1 million by the sexual health clinics, but around 700,000 antenatal screening, and we've got a great antenatal screening program, 99% uptake. And then we go down to medicine, so acute medicine and hospital admissions, around 170,000, A&E, emergency department, sorry, A&E, 72,000, and then the others are a smattering of online testing, drug service testing. So really the bulk of testing is actually in sexual health clinics. But we do know that if you actually look at the prevalence in this test, that actually the emergency departments have the highest number per test. So it's 0.8% prevalence in emergency departments. So the NICE guidance actually states that in areas where the prevalence is between 2 and 5 per 1,000 population, every person coming through who has a blood test should be offered a HIV test. They're also suggesting that new individuals registering with their GP should also be offered testing, and the guidance are actually just out to consultation again, and they're going to sort of be a little bit stricter. And obviously, trusts and organisations have to be NICE compliant, so we would hope that this is going to improve uptake across the UK even more. So, why test? Well, our sort of treatment guidelines have changed dramatically over the last 20 years or so. Initially, we only treated people who were very ill and had very low CD4 counts. But as time's gone on, we've learned from research, from adaptation of development of new drugs, having cleaner new drugs, generic new drugs, and cheaper new drugs, that actually you start treatment when you make the diagnoses. I was speaking to a patient yesterday who told me that the 10 years of waiting and watching his CD4 count drop from 600 down to 350 so he could start treatment was the most painful time in his life, and that he was really celebrating the fact that a friend of his who was newly diagnosed was going to be starting treatment literally within 90 days of actually having the diagnosis. So the START trial was incredible. It gave us permission to start treatment, something that we'd actually been talking about for about 13 years prior. So going back to that mathematical modelling of 2008 and how we should really seriously be thinking around things. So there's a reason for testing, is that we start treatment immediately. But also it has a vast impact on survival. So this infographic looks at the 20-year-old diagnosed as HIV by year of diagnoses and their survival. And you can see if they were diagnosed, I can't read from here, back in the early 90s, that they would probably live for about 8 years. Yeah, not good really. So they'd reach 28 maybe. But actually, if you look at what today's data shows us, is that someone diagnosed at the age of 20 now will actually live as long as, maybe even outlive their friends who are non-HIV positive. mainly because they get better care, they get monitoring, they get their lipids done, they get screened for diabetes, they get advice about smoking cessation, they get all their vaccinations, they see doctors every 6 months, they become our friends. I've been looking after people for over 27 years, the same patients, and you get to know them very, very well. So there's a really good news story here. But then we've also known as treatment as something else. We've known that treatment can be used as prevention. So if we look back to the early days of zidovudine being used as part of mother-to-child transmission, we recognise that there was a 60% drop in the risk of mother-to-child transmission if the mother was given zidovudine in pregnancy, an IV infusion during labour, and the baby got zidovudine for a month. We've moved on from all of that, but what we do know is that if a mother is actually taking antiretroviral medication, the risk of her child getting HIV is probably 0.3%. But it's actually taken us a very long time to actually come round to think, if we actually use treatment as prevention, can we use it in this setting, can we use it for sexual transmission of HIV? So in 2016 and 2017, there have been two major studies called the Partner 1 and Partner 2 studies, which have both looked at discordant couples. So couples where one partner is HIV positive and the other is HIV negative. The partner who is positive is known to be on antiretroviral therapy with an undetectable viral load. And they have monitored those couples over a period of 2 to 3 years, actually checking the negative partner's HIV status over that period of time. And they've actually, and during that time, they've been having unprotected sex of all manners. The first trial had 58,000 sexual events monitored, and the second trial had 77,000. So there's a huge amount of sexual acts that have been monitored over this period of time. And what these two trials showed, that there was zero HIV transmission from the positive to the negative person. This was a phenomenal breakthrough, something that we now call undetectable equals untransmittable. And I would like you to go away with this thought today, that if you know someone who's HIV positive and they've been on treatment for more than 6 months, then the chances are they are completely uninfectious. This is a major, major thing for not only individuals who are affected by HIV, but also for us as society as well, and us as clinicians to understand this. So the risk of onward transmission is zero. Not maybe, might be, or could be. It is zero. And we need to get that information out to not only the clients, but also to our patient group. So, when I started off, I talked about 1990. So, where are we in the UK? So, we've actually achieved that target already, a year in advance. So 92% of people in the UK, we now are aware of their diagnoses. 98% are on treatment, and 96% of those individuals are actually got undetectable viral loads. So we've cracked it, haven't we? Or have we? But that's been a phenomenal move forward. So now, what about primary prevention? Simon talked about our rising rates of STIs. This is a graph of HIV, syphilis and gonorrhea for the last 10 years, and you can see, despite all the messages going out there about safer sex, around condom use, we are seeing an increasing rate of gonorrhea, but also an increasing rate of syphilis. Not only are we seeing syphilis, the majority of these infections are seen in the gay population, but we're also seeing crossover into the heterosexual population, but also seeing women presenting in late pregnancy with syphilis, and we're actually, for the first time in the last couple of years, seeing neonatal syphilis. Our concern is the message about safer sex or condom use hasn't got through, and certainly research shows that there's been a significant drop in the number of people actually using condoms. But actually, if you look at the younger age group, they're not having sex, they're all on their iPads and whatever. So, is there something we can do about primary prevention for those people who don't want to use condoms? There's been significant worldwide studies around pre-exposure prophylaxis using a significant different modes of treatment, so through vaginal preparations, through oral preparations, vaccines, which we know are not getting anywhere. But there has been a major breakthrough with using Truvada as a pre-exposure prophylaxis. The PROUD study, which was terminated early, looked at 500 individuals, of which 250 were started on PrEP very early on, and the other 250 started a year later. They had to abandon the trial because there was such a difference in HIV acquisition between the two groups. Unfortunately, in England, NHS England would not fund Truvada in the sexual health clinics. But the devolved nations, with a bit of a battle between Scotland and Wales, actually decided to go ahead and actually give PrEP free on the NHS to all individuals who qualified. And these were individuals who had high risk, condomless sex, who had risks of STIs or had been diagnosed with an STI in the previous 3 months. Northern Ireland has just come on board as well. So the PrEP Impact trial was to recruit in the first place 10,000, and then in January of this year to recruit another 10,000 individuals. There has been huge public outcry amongst the community around this because in the meantime it is reckoned that individuals are acquiring HIV where they could potentially have not if they had taken PrEP. Part of the community response has been fascinating. So an individual set up I Want PrEP Now, which is a sort of not-for-profit online system where individuals can buy their own antiretrovirals for PrEP. And they've done a huge amount of work in raising awareness amongst individuals at risk. We have now heard that the local government association are going to fund the sexual health bit of the PrEP. NHS England pays for the drug, but the actual service is provided from the local government. And this is where the politics come in. So you've got a HIV service run and commissioned within the NHS and with the NHS England, and then you've got sexual health services being provided and funded through the local government association. If you don't stop HIV in the beginning, all you're doing is flipping the cost back into the NHS. So there's some bizarre issues here, and the fragmentation of services, as Simon pointed out, has been a major issue. So, impact of PrEP. You can see here now that actually there has been a significant drop. There's been a 22% drop in HIV. So we think that there's been quite an improvement, probably due to PrEP, but also the fact that we're using treatment as prevention. The fact is that messages are getting out there. In Scotland, they've just published their data, and of the 1,872 individuals who have had PrEP, they have seen 2 seroconversions, but that would be still less than anticipated if they weren't on PrEP. They have pointed out that one of the things that PrEP has done is not is actually about bringing at-risk individuals into their clinics. So 28% of individuals were attending for the first time in 2 years, but also 19% of the people that actually presented and were eligible for PrEP had never been to their service. So presenting for PrEP also meant that they now have 3 monthly STI checkups. They get their Hep B vaccination, their Hep A vaccination, and their HPV vaccination. So from a public health point of view, that has been a brilliant sort of campaign that's had spin-offs that are really quite positive for onward prevention. There also needs to be the political will, and from the UN AIDS point of view, there's the fast-track cities, but also our own health, it's not my health minister, the English health minister has also committed to eradicating HIV by 2030, and that would be really interesting if we can do this. Is there a fly in the ointment? Unfortunately, yes. All is not rosy. So this is a paper from the Lancet around the re-emergence of HIV in Glasgow. Glasgow has always had people who inject drugs having a high prevalence of hepatitis C, and in the past they've had outbreaks of HIV. But over the last 3 years, they have noticed a huge rise in new cases of HIV amongst their injecting drug users. They were running along at around 10 a year. So there's been 130 cases in 3 clusters that they've looked. It's been a very interesting outbreak because one of the things here, they've been 61 been in men, and they have also been linked into a high incidence of Hep C. But the one thing that has come out of this is that these are men that are involved in social exclusion. They're mainly homeless, they've spent some time in prison, they are detached from health services, but actually they are in contact with their needle exchange programs. And in Glasgow, they're now actually lobbying to see if they can have safer injecting rooms for individuals so they can monitor this. This paper is fascinating because they've done the phylogenetic profile of all the cases and shown how they've gone from one group to the other. And the gap has been only about 6 months, and this has been people within care. So we've got to always be prepared that something might change. And throughout this, one of the things that's probably worrying me is that there's still a significant amount of stigma, a bit of ignorance within physicians, I'm afraid. I had a patient who put a complaint in because he was on PrEP, so he was on Truvada. He was admitted with a stroke, nothing to do with his PrEP, and the physician who saw him said, "Oh, you must have AIDS." Sorry, the patient just challenged, this was an open ward, challenged and said, "No, I'm on pre-exposure prophylaxis." What's that? So you are now all enlightened. I'm really pleased that you're here and that you will pull up anyone that actually doesn't know anything about PrEP, doesn't know anything about you and you, because our patients deserve to actually not be stigmatized. And we have a stigma index. So every 2 years, we actually survey all HIV positive individuals by their choice to actually come up with what's happened to them. And if you actually have a look, that there's an intergenerational issue. The older individuals have actually got major issues with clinicians, and around 5% feel that they've actually been refused healthcare because of their status. The younger generation, the ones that have acquired their HIV through vertical transmission, have a much cooler impact, sort of attitude to HIV. But even so, there is still a significant amount of stigma, and we need to actually eradicate that. So, can we achieve our goal? Yes. So we need the buy-in with healthcare professionals, treatment as prevention, and that will only come forward if we do as much testing as possible. We have some political will, probably not enough, and we need to eradicate stigma. And it really all starts with you. Thank you very much.